General anesthesia is rarely experienced as sleep. It is a chemically induced coma, requiring absolute continuous precision from the moment the patient goes under. For decades, ordinary infusion pumps have pushed these drugs blindly. They deliver a flat, continuous stream of liquid into a human body whose biology is constantly shifting under surgical stress. This creates two extreme frontiers of failure. If the dosage is too low, the patient risks intraoperative awareness, waking up paralyzed on the operating table. If the dosage is too high, the drug can fatally suppress their breathing and circulation. Relying on a static chemical push forces the anesthesiologist to play a highly dangerous guessing game. They have to constantly manually adjust the drip rate to keep the patient balanced on a razor-thin margin of safety. The target controlled infusion, or TCI pump, approaches this problem entirely differently. It operates as an active, calculating mathematical intelligence. Instead of selecting a drip rate, the anesthesiologist selects a target concentration. They tell the machine exactly how much anesthetic is needed at the effect site, which is almost always the brain. The computer inside the pump then takes over. Every few seconds, it recalculates the required dose. If the drug levels start to fall, it instantly speeds up the infusion. If the concentration rises excessively, the pump slows down. This continuous feedback loop creates a dynamic, reactive autopilot that maintains a steady drug level as the body's chemistry changes. Every procedure begins with a takeoff phase. The TCI machine delivers an initial, rapid surge of drug, called a bolus, to quickly raise the plasma concentration in the blood and put the patient under. To maintain that target altitude, the machine relies on pharmacokinetic modeling. This is a complex mathematical world running continuously inside the computer. This chart shows how the AI actually visualizes human biology, imagining the body as a simplified series of interconnected mathematical compartments. At the center is the central compartment, representing blood and highly perfused organs like the heart, which receive the drug instantly. Attached are peripheral compartments, representing slower absorbing muscle and fat. The computer calculates the drug's movement as it washes back and forth between these nodes, constantly updating its math for metabolism and elimination. By mathematically deconstructing the patient's anatomy, the TCI system can predict how a drug will distribute throughout the body before it physically happens, keeping their vitals entirely stable. Early versions of these calculations, like the famous Marsh model, made their predictions based almost entirely on the patient's body weight. But an 80-year-old and a 20-year-old of the same weight process chemicals differently. To fix this, advanced systems like the Schnider and Minto models evolved to incorporate patient age, their specific height, and lean body mass, highly individualizing the flight path. Children distribute drugs so differently from adults that they require entirely separate mathematical parameters, governed by highly specialized models like the PGs. Yet this predictive brilliance is limited by physical blindness. If an intravenous line kinks or becomes blocked during surgery, the machine's sensors cannot see the obstruction, and it will silently assume the drug is still entering the bloodstream. If muscle relaxants are being used during that blockage, the patient might regain awareness while completely unable to move. Conversely, if a target is set too aggressively for an elderly patient with heart disease, excessive concentration can trigger massive, rapid hypotension. The AI maps the interior numbers of a human body, but because it cannot physically see the patient, it strictly requires the continuous vigilance of a human co-pilot. As the surgeon finishes their work, the descent begins. The anesthesiologist instructs the machine to gradually lower the target concentration. The TCI pump immediately begins calculating the rate of tissue washout. It analyzes the specific speed the drug will leave the compartments, predicting the exact moment the patient will wake up. This graph maps the descent to consciousness. The target concentration slowly drops until it hits roughly 1 microgram per milliliter of propofol, the exact threshold where the coma ends and the mind returns. Because this landing is mathematically guided rather than abrupt, heart rates remain stable, stress hormones barely spike, and patients experience less post-operative nausea. This synthesis of pharmacology, mathematics, and artificial intelligence provides a level of control over the return to consciousness that manual systems cannot replicate.